Health and the Division of Consumer Affairs and Law and Public Safety. As Mary said, my name's Eddie Bresnitz. I was formerly the New Jersey Deputy Commissioner of Health and the state epidemiologist over a decade ago, and have come back out of retirement to basically help with the COVID response in the department. And I'm currently serving as the advisor medical consultant to Commissioner Judy Persicelli. And on behalf of the Commissioner, as well as the Department of Health, we really want to thank all of you for what you're doing to provide care to all your patients in these really very difficult and unprecedented times. As the pandemic has grown and spread globally, so it has done in New Jersey as well, as I'm sure you are well aware. The DOH, oh, did I lose you?
No, you're still there, Eddie.
Okay, the DOH and all state agencies have strived to keep up with the ever-changing situation and issue guidance for all healthcare practitioners and healthcare facilities. But I think, as you can appreciate, as the situation changes, guidance by necessity also changes. So what may be guidance and policy today may change tomorrow. So just be aware of that. Now, as Mary indicated, we appreciate that you have a lot of questions, and more than half of the program today is devoted to your questions, and hopefully we can provide some answers. But we can't answer all the questions, but we hope to address many of them. This is the first ECHO session on COVID-19, but not the last. We'll have others over the next few weeks. So thank you again for all you're doing to care for patients and protect the public's health in New Jersey. And with that, I'll turn it back.
Great. Thank you, Dr. Bresnitz. I appreciate that. We also have some greetings from the New Jersey Division of Consumer Affairs. So next I'll introduce Mr. Paul Rodriguez, the Acting Director of the Division of Consumer Affairs, Office of the Attorney General, Department of Law and Public Safety. So Mr. Rodriguez.
Well, thank you very much. It's a pleasure to be here. Thank you so much for having us. Thank you to DOH, Project ECHO. I want to say, just to start off with, I too want to thank everyone on this call. I want to thank everyone who is providing valuable healthcare services. We are here as a service to you, and just to give a bit of an overview on what we do here at the division. So the Division of Consumer Affairs, we sit within the Department of Law and Public Safety, the Office of the Attorney General. We oversee 51 professional and occupational licensing boards. Those are the boards that not only license, but also regulate the professions of over 750,000 licensees here in the state, over 300,000 of which are healthcare professionals. So we're talking about medical doctors, nurses, and many others. We have been partnering with our state agencies, with the governor, with the attorney general, to fight the COVID-19 pandemic. We are looking for ways to address the needs of the licensed individuals, not only sharing information with them, but trying to eliminate any regulatory barriers as quickly as possible. And so sessions like this, we can talk a little bit, are helpful to talk a little bit about what we're doing, but also the Q&A session is incredibly valuable so that we can hear from you as to some of the issues that you're seeing so we can address them as quickly as possible.
Excellent. Thank you so much, Mr. Rodriguez. And we'll field you some of our questions, certainly, and look forward to your remarks related to telehealth as well. We've got Ms. Jennifer Fearson, a policy advisor to the New Jersey Department of Health, to talk a little bit about the state and local ecosystem overview and some key resources that are available. Jennifer, are you there?
Yes, good morning all. As my colleagues mentioned, the Murphy administration really has taken a whole of government approach to responding to COVID-19. This includes a coronavirus task force that was enacted under Executive Order 102 on February 3rd, and which is led by the Department of Health and includes a multi-agency cohort. On this slide, you'll see a summary of some of the key offices that you as a healthcare provider are likely to interface with during the COVID-19 crisis. At the state level, as Paul Rodriguez mentioned, the Division of Consumer Affairs is sort of the point for provider licensure, whereas the health systems branch within the Department of Health is providing guidance on facility licensure. Meanwhile, our communicable disease service, from which you'll hear several of our experts today, is taking the lead on our surveillance activities. The Office of Emergency Management coordinates supplies, and with them, through them, you will be requesting PPE at the county level. The Office of Emergency Medical Services oversees our EMTs, and our Office of Local Public Health coordinates contact tracing through our local and county health departments. And finally, our public health and environmental laboratories are some of the leaders in terms of our state laboratory capacity and are working closely with the commercial laboratories across the state. Next slide, please.
Great.
As I mentioned, there is a lot of guidance and information in the works, and we hope that you will be consulting this information as you move forward in your practice beyond what is shared today. This information will be shared in the follow-up email, but just briefly, guidance documents are rolling out for healthcare providers at the Department of Health and at the Department of Consumer Affairs websites. The Centers for Disease Control and Prevention is constantly rolling out information, and for information across state agencies, press releases from the Office of the Governor, as well as the COVID information hub for New Jersey, which can be found at covid19.nj.gov. As you are interfacing with the public, as your patients and your families and such, the public can contact us with questions. There's a call center, and that's managed through our 2-on-1 service. As providers, our communicable disease service is also fielding some questions. As I mentioned, PPE and other resource requests need to go through your county Office of Emergency Management. So thank you, and I will turn it over to my colleagues.
Great, thank you, Jennifer. It's such important information at this time. We're going to move forward. We have quite a number of presentations to get through. Our first presentation will talk about COVID-19 and epidemiologic picture or perspective from the United States as well as here in New Jersey. Our presenter is Dr. Lisa McHugh, who's Program Coordinator, Infectious Diseases Epidemiology through the New Jersey Department of Health, Division of Epidemiology, Environmental and Occupational Health, Infectious and Zoonotic Disease Program. Dr. McHugh, I believe you are unmuted, so if you can go ahead with your remarks, we appreciate it.
Great, thank you everybody. Thanks for joining us and talking to us about this very valuable topic. Next slide, please. So today I'll just be covering some of the epidemiologic aspects and focusing on the information that we currently have about cases that are occurring within New Jersey. So first, just a little bit of an overview of COVID-19 disease, basically what we know, and there's a lot that we don't know, but let me just try to present to you some of the information that is currently known. So as far as the incubation period, mostly the incubation period has been cited as somewhere up to 14 days after exposure, and much of that information is based on what we know about previous novel coronaviruses. But in all likelihood, with many of the cases and some case studies that have been done in a lot of different places, it does seem like most cases present with illness within about 4 to 5 days after exposure. The spectrum of illness, it has been reported, and we continue to see a very wide spectrum of illness from very mild disease with non-specific signs and symptoms of acute respiratory illness to very severe disease with pneumonia and respiratory failure and septic shock have been reported. I know that there's a lot of questions out there and that were previously submitted about asymptomatic and subclinical infection. And I think that information is still quite unclear. There are a lot of reports and some studies that have been reported that do indicate that this is certainly a potential. I think what's a little unknown is that much of this is based on individuals who have had a positive test with either no symptoms or subclinical infection. And I do think there needs to be some additional studies to determine whether those people actually went on to develop illness, and the detection of those tests were really based on some virus particles that were able to be detected on a PCR-based test. And so I think there's a lot of information that is still unclear on that particular topic. As far as what are the risk factors for the development of severe illness, well, we do know that severe illness can and is occurring in individuals, healthy individuals of really any age, but it does seem like the predominance of much of that severe illness and deaths are occurring in individuals of advanced age, and in particularly those with certain underlying medical conditions. And it does seem, based on some of the studies that have been done, that the larger number of underlying medical conditions that an individual has does correspond with increased severity of illness. Next slide, please. So as far as route of transmission, again, some of this is a little unclear, but we are learning a little bit more each and every day. What we know right now is that it is person to person, likely via a droplet transmission. Of course, as we've seen with other respiratory illnesses, including influenza, there is some airborne transmission that can potentially occur, particularly through aerosol generating procedures that might be done in the healthcare setting. And I think because so much is unknown, that is why you are seeing the recommendations for transmission-based precautions being airborne with eye protection. And so that is something that you will see, and that is part of the reason for that is some of the uncertainty around the route of transmission. With regards to period of infectivity, there have been limited studies, although there has been some that talks about the similar, when the viral load is as a proxy for a potential period of infectivity. And some of those PCR-based tests have found, again, that higher viral loads seem to be occurring just soon after initial illness onset. And this is pretty consistent with what we know about other respiratory illnesses. And so we also know that the viral shed is highly variable and has a significantly wide range. It's possible that it's longer with severe illness. Much of this data has come from individuals that are doing a post-illness kind of clearance testing to determine when they're no longer shedding. And in some circumstances that virus has been detected 10 days plus beyond an individual illness onset. And so it's really kind of still pretty unknown, but we do know that it is a pretty wide range of when that period of infectivity does occur. As far as immunity, antibodies are induced after infection. That has been studied. And what is still unclear, though, is that whether all infections are actually mounting a protective immune response from the actual illness. Next slide. So let me just apologize straight off the bat. This is a quick moving target. And so this data is actually what I pulled on Saturday and Sunday afternoon. So some of this is outdated by a few days, but I will try to update the information as best I can with a couple of notes that I have on the side. And so I'll present some of the information both from the United States and then delve into a little bit more deeply into the information specific to New Jersey. So first, this is actually the United States, the EPI curve, and I'm just going to update the numbers. So this data was actually as of March 27th, but as of March 30th, the numbers have actually increased to 163,539, with 2,860 reported U.S. deaths for a case fatality rate of about 1.7%. Next slide, please. And so this again is a map of the United States, and you can see that the legend is actually depicted, the darker green or darker red colors, excuse me, indicate the larger numbers of case counts. And while this information has been updated, the further on as far as today's numbers are concerned, the red states are just a little bit redder. But you can see that there are some areas, particularly in the Northeast and on the West Coast, as everybody has been aware of, that have been significantly hard hit. Next slide, please. So let me just talk a little bit more about the actual numbers. And again, as I mentioned, this data is as of March 28th, and I'll try to point out the differences in the information that is a little bit more recently where there is some. This number is reporting 11,124 confirmed, laboratory confirmed cases. This number is currently up to 18,696 as of yesterday. with 267 deaths, and we'll talk about that in a subsequent slide. Here you can see that the age range of the laboratory confirmed cases, again, those less than 17 years of age make up only a very small percentage of what we're seeing, with a kind of an increasing number of hospitalizations and a fair number of cases, excuse me, not hospitalization, cases within the 30 to 64 year age range. The mean and median age are right around the same at about 49 years of age, and that has these numbers have remained fairly consistent even with the updated information that we have out as of today. Next slide, please. So there's a slight predominance in sex by males by a slight predominance. And again, that number has not really significantly changed over the past few days. Next slide, please. So this is the New Jersey map of cases. And again, you can see that the largest number of cases have been occurring in the northeastern part of New Jersey, with a lot of individuals in those areas connecting actually into New York City and New York State. But that is where we continue to see a growing number of cases within that population. While we are not seeing large numbers of cases, particularly on our southern and western border, we are seeing cases that are occurring, and those numbers are slowly creeping up each day. Next slide, please. So when we talk about death reporting, and again, these numbers were as of March 28th. The new number as of yesterday was 267 laboratory confirmed deaths. The overall case fatality rate is only slightly higher yesterday than what is presented on the slide, with a 1.42% case fatality rate. The overall hospitalizations, and again, I will be, you should be cognizant that this is only of a smaller subset of the overall laboratory confirmed cases. So we're only presenting that information on data which we are absolutely sure that we know whether the person has or has not been hospitalized. So it is a smaller proportion of the overall laboratory confirmed cases. And in this particular case, the overall of all cases, this is not a number of currently hospitalized, but of all the cumulative cases that have been reported, about a 32% hospitalization rate. This number has pretty much remained consistent of about a 31 to 32% overall hospitalization rate among all the cases that have been reported. Next slide, please. So this is talks about the hospitalization specifically by those particular age groups. And here you can see that certainly those less than 29 years of age make up only a very small percentage of those individuals being hospitalized, with the far greatest number of hospitalizations occurring in those aged 50 years of age and older. Next slide. And then this particular graphic actually is a breakdown of those within each of those age groups that have been hospitalized. And so along the far right column, you can see the actual number of cases for whom hospitalization status is known in each of those particular age groups. And the red areas in each of the lines denotes the percent that have been hospitalized among those individuals in those age groups with known hospitalizations. And of course, you can see, as was illustrated in the pie chart in the previous slide, those greater than age 50 are being hospitalized far greater than those less than those age 50. Next slide, please. So as far as deaths are concerned, this is a bit more of a breakdown of the overall deaths. As far as sex is concerned, again, a slight male predominance in deaths. The age groups, again, by far the largest number of individuals who have died are in those who are 60 years of age and older. And as far as underlying conditions are concerned, a large number, 61% of the 140, as far as this slide is concerned, have had some type of underlying condition, and we're still working on trying to get additional information on underlying conditions on the remainders of these lab confirmed deaths. I will also point out that there is a pretty staggering statistic, and that about just shy of 20% of those deaths that have been reported to us are associated with some type of long-term care facility, and those numbers, of course, are tragic. Next slide, please. So this is the an epidemic curve for the current trajectory of the outbreak as it's occurring. This is overlaid with some kind of important high-level details that have occurred associated with the outbreak. And you can see that the trajectory continues to increase. I will also point out that the box that you kind of see is a bit of a lag period that does occur as we begin to investigate cases. A lot of times these will shift into different types of onset dates as we get additional information. And there is a lag, certainly in the lab reporting to our data systems within the State Health Department. Next slide. And so this is an overall cumulative total graph. So this just simply shows the cumulative number of cases that have occurred, with new cases each day occurring in the darker orange shade. And so you can see that we had on the 25th of March kind of a pretty steady number of cases, and then a pretty significant jump beginning on March 26th, and that number has continued to climb each and every day. Next slide. And so I will close with kind of a final slide of percent positivity. And again, this is a graphic that simply shows a subset of the laboratories that are reporting to the Communicable Disease Service. And these are laboratories in which we do have both numerator and denominator data. So we get both positive and negative test results from those. So this is not from all of the cases that have been reported to us, but it is a far large majority of those. And you can see that as of March 28th, the percent positivity was about 35%. This number has continued to grow over the next few days and is currently, as of yesterday, at a 38.9% positivity rate.
Dr. Thierson, we've received a number of questions with regards to the contagiousness, the incubation period, and also about quarantining for individuals who have presented symptoms or who are recovering, or again, concerns about exposure to vulnerable populations or household members. So we're going to come back during our question and answer. I have a number of questions from our chat and from our that have been submitted that I want to make sure we get to. For our next presentation, we've got Dr. Barbara Montana, who's a medical director at the New Jersey Department of Health, the Division of Epidemiology, Environmental and Occupational Health Vaccine Preventable Disease Program. She's going to be presenting on understanding the basics of infection prevention and control in the outpatient setting. So, Dr. Montana, I believe you are unmuted. If you can go ahead.
Good afternoon, everyone, and thanks for joining us on this webinar, and thanks to all of the providers on the front lines providing care. So as was said, I'm going to be talking about the very basics of infection control with a focus on outpatient settings. If you could start with my first slide, please. So COVID-19 is caused by a beta coronavirus, which is an RNA virus. It's most similar to the virus that causes SARS, which reared its ugly head in the early 2000s, and it's less similar to the virus that causes MERS. As you can see from this slide, the virus that causes COVID-19 is detectable in the air for up to about 3 hours and on surfaces for days. That being said, though, we really don't know how much transmission is occurring via these mechanisms. This was done in an experimental setting and not in real life, so we're not sure what that means in terms of actual infectivity from these various means. Next slide, please. It's important to think outside the personal protective equipment box when you're coming up with ways to make your office safer for yourself and for your patients, since we know that PPE is in limited supply. So what are the things that you can and should be doing now? Well, first of all, you can limit how the virus gets into the building in the first place. We've asked that people cancel elective procedures and well visits and really focus on the care that has to be administered face-to-face. We recommend that you screen people for symptoms by phone prior to visits. Use telemedicine as much as possible, and I know that you're going to hear more about that later. And also doing things like limiting the number of people who accompany patients to visits. Really try to streamline it so that you don't have extra people in the environment. Other things that you can do, you can also institute engineering controls. Now, this can be more difficult depending on your office setting. Some physical plants are less amenable to these kinds of engineering controls. So you need to think of ways that you can alter the environment to make it safer, like putting up plexiglass at the reception station to actually provide a physical barrier to staff to protect them. You can also do things like opening an alternate entrance so that sick patients can enter differently from well patients that are being seen in the practice. Something else that you can do, you can also institute administrative controls. You need to think of ways that you can change how people actually work. And I know that this can be challenging because people get very set in their ways, and any sort of change can be disruptive and slow things down. So for instance, if you have a person with respiratory symptoms to evaluate, you can put that person in a room and close the door. And instead of going into the room to get the history, perhaps you can call them on their cell phone to get most of that information and then go into the room just for the actual exam. And one thing that you can do is try not to spend a lot of time in the room to do tasks that you don't have to, like charting in the electronic health record. That's something that you can do when you leave the room outside of the patient care area. The other thing that you can emphasize is all standard precautions, and don't just focus on the limited amounts of PPE. Practicing good hand hygiene is extremely important, and I know you've heard that over and over again. For hand hygiene, we recommend alcohol-based hand rubs or good old soap and water. The alcohol-based hand rub should have an alcohol content of at least 60%. Alcohol-based hand rubs are much easier on the skin, especially when you have to use them frequently. They don't dry them out as much, and they are much easier for you to keep with you when you're delivering care. We recognize that hand washing stations might not be readily available, and that it's time consuming to get to one sometimes when you're in the middle of delivering care. Another thing that's very important is practicing respiratory hygiene and cough etiquette, making sure that people are covering their coughs, not coughing into their hands, coughing into their elbows and such. Be sure that environmental surfaces are being cleaned and disinfected frequently, especially those areas that everybody is touching a lot. And be sure that you're using an EPA registered disinfectant with a label claim for use in healthcare settings. We often see people who are not using the appropriate agent, and be sure that you're actually following the label on the time that you need to allow that agent to remain on the surface to actually kill the organisms. And finally, be sure that you're using personal protective equipment appropriately. And that includes gowns, gloves, eye protection, and respirators or face masks for cases known or suspected to have COVID-19. Next slide, please. So in order to understand the current recommendations for transmission-based precautions, I'm going to discuss what we know about respiratory viruses in general, and then the virus that causes COVID-19. Recognizing, as everybody has pointed out, that what we know about this virus and this situation is changing every day, and that the recommendations from the Centers for Disease Control and Prevention, the CDC, are updated frequently, and then our recommendations are also updated based on that guidance. So for most respiratory infections, standard, contact, and droplet precautions are what are routinely recommended. Respiratory viruses of this sort are generally transmitted across very short ranges, and we usually refer to about 6 feet. That is a radius beyond which most sneezes and coughs are unlikely to reach. With the arrival of a new virus in our community, we always take precautions, And we've done this in the past for novel viruses like the 2009 H1N1. We recommend, in addition to what we normally do for respiratory viruses, a little bit of extra precautions. We then observe very carefully what's happening during the outbreak and update recommendations based on the particular circumstances and observations. And again, we always base our guidance on recommendations from the CDC. So for respiratory viruses, we normally use what people refer to as droplet precautions. For droplet precautions, we ask that patients be placed in a single patient room and that they put a face mask on when they're leaving the room. Individuals who are going into the room should cover their mucous membranes, their eyes, nose, and mouth with eye protection like goggles or a face shield, as well as a mask or other covering of the nose and mouth. The reason is that the virus has entered the body either through direct contact with the mucous membranes, like a splash or a spray from a cough or sneeze. Another modality for infection is if the person has coughed and then left secretions with the virus on a surface, and then you touch that surface. If your hands are not cleaned, you can bring those viruses from the surfaces in contact with your own mucous membranes. That's why it's important not to touch your face and that you keep your hands clean. The other way that I want to highlight, and Lisa alluded to it before, in terms of how people become infected is not well proven, but is an important possibility. We don't usually worry about it too much with things like seasonal influenza and other respiratory viruses, as we have good treatments available and the ability to provide care to somebody who might become sick is reasonably well established. However, when there is a new or emerging pathogen like we have here, we also take into consideration the possibility that when you're near a coughing or sneezing person, you can inhale small droplets. These are tiny droplets, also called droplet nuclei or aerosols, that don't shoot across the room and land on your eyes, nose, or mouth, but instead they float around the person who's coughing. And it is conceivable that you can inhale the infectious material this way. That's why, rather than simply using droplet precautions, the CDC currently recommends that people use respirators like disposable N95 filtering face pieces or other higher level respiratory protection like PAPRs, which are powered air purifying respirators. These are important devices to be using on the off chance that near the patient you might inhale infectious material. What we are not seeing, and the reason we are not using full airborne precautions, is any evidence that this virus is transmitted over long distances, the way that measles or tuberculosis is spread. These are diseases that are truly airborne and can be transmitted efficiently over longer distances. What we are seeing with this virus to date still reflects that close contact required for transmission that's more in line with other respiratory viruses. For that reason, we do not recommend the routine use of a negative pressure airborne infection isolation room. As you recall, negative pressure rooms are to protect the facility from infectious material. The air goes from the hallway into the room and through a filter, so people outside the room don't have to wear respiratory protection or other PPE. In the case of COVID-19, CDC does not see a need for that, but we do continue to remind people to use negative pressure rooms if you can for aerosol generating procedures. Aerosol generating procedures include things like sputum induction, intubation, and suctioning. One thing that has become very clear is the fact that our supply chains are being strained due to the fact that other countries are being similarly impacted by this global pandemic. For this reason, many providers are noticing important supply limitations in terms of respiratory protection and other PPE. We want to make sure that there's an adequate supply of PPE for providers who are performing aerosol generating procedures on patients with COVID or who are caring for patients with other known to be airborne diseases like measles and tuberculosis. So the CDC has recommended that we focus the available supply of respiratory protection on procedures and activities that have the highest risk to healthcare personnel and be sure we maintain that supply. In the interim, we have enough evidence to suggest that surgical masks or face masks provide a good level of protection. Certainly, these masks block direct exposure of the nose and mouth to respiratory secretions. In addition, studies have compared infection rates with the use of surgical masks versus respirators, and to date have not demonstrated a major difference in the incidence of influenza and other types of respiratory viruses. The CDC does continue to look at this very carefully, but for now is saying that face masks can be used for lower risk practices, things like routine assessment of COVID patients and general evaluation of somebody who's coming into the healthcare setting. We don't want that to be the case, however, for aerosol generating procedures, like I mentioned before, intubations and such. The most important thing to remember in terms of PPE is that protective equipment is by no means the most important thing when it comes to preventing transmission of infection. PPE is great, but it is much better to see if there are other ways that you don't need to use PPE, as I mentioned earlier, by using these different kinds of administrative and environmental controls. Next slide, please. The other thing I want to mention is that you really have to be sure that you're donning PPE correctly and that especially you're removing it correctly. There's really a sequence that needs to be followed. Healthcare workers can easily contaminate themselves if they're not removing the PPE correctly. And you need to be sure to perform hand hygiene whenever you are removing PPE. And lastly, I want to mention masks on patients. I know that we are frequently asked that question. The most effective thing that you can do when it comes to the use of a mask is to put it on an ill person, especially if the person is coughing. Covering the mouth and nose of the ill individual has a great impact and reduces the risk of contaminating the environment and exposing somebody else. So just to recap, we're at a point where the CDC has made permissive recommendations to say that, especially in times of a shortage like we have now, it is okay to perform routine care wearing a face mask along with eye protection, and ensure that you reserve that higher level of respiratory protection like N95 masks for those high-risk procedures. Once the supply chain resolves itself, then you can consider resuming use of the respirator for care of these patients.
Great. Thank you, Dr. Montana. We're going to come back and revisit during our question and answer. We've received a number of questions regarding PPE from our individuals on the call today, and also regarding hand sanitizer questions, again, related to supply chain issues and the like. So we'll come back during Q&A and revisit those issues as well. Our final presentation will be telehealth opportunities under new regulatory guidance. This is from Paul Rodriguez, again, from the Division of Consumer Affairs. Paul, your line should be unmuted and you should be ready to go.
Thank you very much. Thank you very much. We can go to start the presentation on the next slide. So as we noted earlier, the division oversees 51 professional board that's over 300,000 healthcare practitioners in the state, most notably for this called the Board of Medical Examiners, but also we oversee all nurses, pharmacists, respiratory care therapists. Go to the next slide. As noted previously, the Governor Murphy has really instituted and mobilized a whole state approach to fighting the COVID-19 pandemic. As in furtherance of that, he has signed executive orders promoting social distancing, as we've heard how important that is by previous commenters. We've also been restricting elective medical procedures. In addition to that, there's been a number of other measures that have been taken. For example, recently there have been restrictions in the prescription of hydroxychloroquine and other drugs that are in short supply in the state. We are continuing to work with our other state partners, including DOH and other state agencies, on guidance that is being provided to healthcare professionals directly, to licensees directly, either out by the Division of Consumer Affairs or the individual licensing boards. We are also in the days and weeks ahead taking further measures to increase the supply of healthcare providers that are, again, in short supply. Now, all of that said, one of the most key measures here, and one of the things that we've been very focused on, is encouraging and increasing the use of telemedicine in the state. This is something that we have been doing, and I see that my video has stopped. I hope you can still hear me. This is something that we have done together on our own. This is also something we've done in conjunction with the governor and the legislature. New Jersey has passed a telemedicine statute that's already. There was a new telemedicine statute that came into effect very recently in response to the COVID-19 pandemic. And I just want to talk a little bit about what the current regulations are, and then what is moving forward and what is changing currently under the declared state of emergency. So most importantly, and also just to set parameters here, I'm going to be discussing primarily the telemedicine regulations and the telemedicine, some of the practical steps. I'm not going to be addressing here a lot of the billing concerns, which are very understandably can be top of mind and are equally important to providers. The Department of Banking and Insurance has taken emergency measures with regard to billing. And actually, one of the suggestions is that we may want to have a further, I understand we're discussing perhaps having a further discussion just on telemedicine, where we can answer more questions. Now, on telemedicine, first of all, I want to stress how important it is that we do encourage providers to use telemedicine where possible. That is where the use of telemedicine is consistent with the standard of care. We are trying to make it easier and encouraging healthcare providers to be able to provide that care over the phone, via video, not have people come in personally to your office, which increases the chances to spread the disease, not only to infect healthcare providers, to affect people in the staff, and then put other patients at risk. So a couple of the things that I think will be important to note. I want to dispel, there are myths that we hear every once in a while, and I want to clearly dispel them. One of them is that telemedicine is not currently available in the state of New Jersey. There are each one of the healthcare boards is individually promulgating telehealth and telemedicine regulations. That does not mean that those professionals need to wait in order to provide telemedicine and telehealth. That was never the case. The law is self-effectuating. With regard to the Board of Medical Examiners, for example, there is an already published regulation that's being adopted on April 20th. That just spells out and provides a little bit more guidance. You can look at it right now. It's set to be adopted on April 20th, but it is in no way more restrictive than the statute is currently. In addition, we hear things, for example, that it is not telemedicine is not available in the mental health setting or in different settings, and that is not the case. Telemedicine is very much encouraged during the state of emergency and elsewhere as well, and in ordinary times. I will also say, so I want to stress some of the changes that have taken place recently. So most importantly, in order to provide telehealth and telemedicine services in the state, one of the requirements has been, there's been a lot of requirements in order to protect HIPAA information, that all communications and be conducted with synchronous audio and visual, and using a vendor that is HIPAA compliant. Understanding that there are a large number of patients and a large number of medical providers that may not have access to that HIPAA compliant technology, and the need that currently exists, we've relaxed those regulations. Right now, use of a telephone alone is sufficient, or the use of audio-visual communications that might be available through just immediately available on someone's cell phone. So if you can just call someone, if they have video on their phone, you're able to communicate with them. That is sufficient for to meet the telemedicine guidelines that currently exist during the state of emergency. I will say there is, we do require all providers to take reasonable steps to avoid the unauthorized disclosure of patient and client healthcare information. So that includes, while you can use FaceTime on a cell phone, for example, you would not be able to have a broadcast over, a social media platform to use, TikTok or Facebook Live or other providers where the public can see the interaction. Now, all of this obviously is subject to the standard of care. That's up to the provider to determine and use their clinical judgment as to when the use of telemedicine is appropriate, but they are very much encouraged to do so whenever they can. If we can move on to the next slide, please. The other thing that I'd say, so there is, under the current statute, it is difficult for a provider to set up and establish a doctor-patient relationship using telemedicine. So the statute contemplates that you will have a doctor-patient relationship that then can be continued on afterwards using telemedicine. During this state of emergency, we've significantly relaxed those rules so that there would not be any restrictions to establish a doctor-patient relationship for the first time using telemedicine and telehealth. Again, all of those individual encounters are subject to the standard of care, when it's appropriate. But again, we want to eliminate the barriers to providing those services when appropriate. We are also trying to, there were certain regulations that in certain instances restricted where the doctor or the patient would be. We're eliminating those. On just a regular regulatory point, the New Jersey rules with regard to providing telemedicine apply whenever either the doctor or patient are in the state. And one of those requirements that remains is that you must have a New Jersey license to practice if either the doctor or the patient are in the state. Now, there's been some changes there also for the state of emergency that I want to highlight. One of them is that you do not need to be licensed in New Jersey if you are providing care for specifically related to COVID-19, or if you have a pre-existing doctor-patient relationship. So we have, for example, a large number, as universities around the country close, those students come back to New Jersey if they have a pre-existing relationship with an out-of-state doctor. That doctor does not have to be licensed in New Jersey. However, we have also created an emergency reciprocity license for doctors in other states who wish to provide telemedicine. They can become licensed and through an expedited pathway here in New Jersey, again, just during the duration of the declared state of emergency. We have, I think we moved a little bit ahead in the slides, and that's right. One of the things that I'll say, again, just some of the big picture items here that we do want to stress because it's one of the most common questions that we get. Again, when appropriate for the standard of care, phone only and audio only is okay. Use of cell phone is also appropriate. Any type of encounter that in the physician's judgment can be can take place using telemedicine, should take place using telemedicine. While we're not going to address on this call, as I mentioned, billing issues, I should note that the Department of Banking and Insurance has instituted emergency guidance that includes, among other things, that for all in-state plans, for all state-regulated plans and insurance plans and HMOs, that they must pay that the same in-network professionals are going to pay the same rate, and for telemedicine services as in-person visits, there may be different codes that may be used, but that is a very important piece of this. We'll also say that we also get a lot of questions about how can you establish consent in a telemedicine context. Those are the same, and such a record keeping is the same as well. We really want to stress that the nature of the call, the nature of the encounter, whether it's in person or over the phone or via video, does not change any of the other requirements. So your record keeping requirements are the same, your requirements for documenting consent are the same, the standard of care remains the same. It's just a question of how you are contacting that patient and how that patient is able to get access to services from you. And I'll stress, we have, we are issuing guidance on this shortly. It's going to be on our website soon. That's in collaboration with Department of Banking and Insurance, with Department of Health, with New Jersey Medicaid. But this is something that I look forward to, whether or not we can answer the questions on the call here. We will be getting the questions in writing, and that will help inform some of the guidance that we put up online. If practitioners have questions, they're encouraged to reach out to the Board of Medical Examiners. The email address is here. There is also, it's a billing question, reach out to DOH or Medicaid as the case may be. But if you are encountering issues, if you're hearing about practitioners that are not able to provide telemedicine services and telehealth services, we encourage you to contact us, because we want to be able to identify what those barriers are to see if there's a way to remove them.
Great, thank you, Paul. Can you just to address one of the questions that has come through the chat really quickly, where can the revised telehealth regulations be accessed?
So they can currently be accessed on the Board of Medical Examiners website. The regulations will be published. Right now, they're also published in the New Jersey Register. The regulations themselves are going to be adopted April 20th, as I mentioned, but the changes and guidance explaining those changes will be up on our website shortly. If possible, we'd like to be able to get them out to the people on this Zoom meeting afterwards, as soon as they're published as well.
Okay, but Board of Medical Examiners website sounds like a good place to start, at least for people dialing in.
Yes, and once they're published, the guidance will also be up there.
Great. So this concludes our formal presentations, but I'd really like to segue into addressing some of the questions that we've received from individuals dialing in today. Truly, the volume of questions has been unbelievable. I've tried to consolidate and capture some of the issues raised as best as I can, but I can tell you the folks here at ECHO at Rutgers will try to consolidate and use these questions to really help planning in our subsequent and upcoming sessions. If Dr. McHugh is still with us, I want to address some of the epidemiology questions that have come up. Lisa, are you still here?
I'm still here.
Great. I wanted to talk a little bit, I want to ask you, how long are we talking about this COVID-19 being contagious?
Right, so thanks for that. So again, we don't, again, there's a lot of things that we really don't know. We obviously know, as I mentioned, that the viral load does appear to be greater with symptom onset. And so the greatest risk of transmission is likely going to be when someone is acutely ill. And currently what we're advising is that if those are individuals that have some type of illness, before they should return to normal work and normal activities, it should really be at least 7 days have passed since their symptoms first appeared, and at least 72 hours after they have recovered. And we're defining that recovery as a resolution of fever without use of antipyretics, and that's when someone should really return back to their normal activities.
So I heard 7 days and 72 hours, is that correct?
Correct. 7 days and 72 hours have passed since recovery, which is defined again as resolution of the fever and improvement in their respiratory symptoms.
And then do we have any data about, with regard to viral shedding? We have a question that came in that states, I've heard 7 to 21 days. When do we consider patients to be no longer infectious? Is that 7 day, 72 hour window?
Well, again, the period that I'm quoting is something that we think is probably the most infectious part when viral load and viral shed is highest. I think that there's been a lot of studies that have been out there where people are being tested post-illness onset. And again, most of these tests are being run with PCRs. And so part of the problem that we have when we talk about PCRs is those tests may be positive, but we don't know whether the viruses that we're detecting in that PCR are actually infectious or they're actually viable viruses. And so we do know that the viral load certainly does go down the further away from acute illness that an individual is. And so as far from. So that general guidance of those 7 days and 72 hours with those two fever and improvement in acute respiratory illness is what we're recommending for, again, returning back to normal activities with an illness.
There was another question with regards to a CDC sentinel practice that we've really come to accept as professionals. We appreciate the simplicity and the power of influenza-like illness or ILI criteria for flu. Are there any ILI-like criteria for COVID-19 at this time?
Yeah, so thanks for that question, and to anybody who happens to be an influenza-like illness surveillance network partner, much thank you to you. Know that those providers are continuing to report that influenza-like illness, and we are working in a number of different avenues, both using syndromic surveillance and the data that is currently being collected by our Sentinel provider partners to really assess whether that can be as simplistic as it is used for COVID-19. Right now, it does appear that that information is tracking quite well with what we're seeing with COVID-19 illnesses. And we're exploring some additional mechanisms to kind of add to that, to potentially add some things like pneumonia or different types of shortness of breath criteria to kind of improve the quality of just our ILI surveillance aspects. And so that is something we are currently working on. And we ask all of our ILI Sentinel partners that are out there to continue doing your part to report. We really appreciate the information. We know that it's challenging, particularly when they're so busy, but we appreciate anything that they can send to us.
Dr. McHugh, if you can address this, but we have received a number of questions about sensitivity and specificity. Do we know anything about the tests that are currently being utilized with regards to those sensitivity and specificity of those instruments?
And so I think that there's such a wide variety of testing modalities that are out there. It's really not really fair to be painting a broad brush for us to give you one or the other specific sensitivity and specificity for a test. So I would encourage you that if you know what your laboratory is running, to really go back and understand what instrument or assay that particular laboratory is running to determine what the specific sensitivity and specificity of that assay is.
Wonderful. I want to switch gears. I have a couple of questions for Dr. Montana. So Barbara, if you're still with us, I want to get to some of these PPE questions from providers. Okay. One of the questions that has come up a number of times, how effective are current data for reusing N95 masks after sterilization? And one of our participants said, please share data, not necessarily opinion on this matter.
So that's a great question. I know that everybody's been seeing a lot of that in the news. Know that healthcare providers are interested in ways to contaminate respirators so that they can be safely reworn. And the thing is, though, while a respirator looks like a fairly simple device, they're actually quite complex. They're all designed differently. The filter materials vary by manufacturer. And this really makes it challenging to develop a single disinfection method that would apply to all models. Currently, there is no CDC-approved method for decontaminating a disposable respirator prior to reuse. The disinfection methods can really make changes in the respirator that can impact its level of protection. The disinfection method can affect the performance of the filtering material. It can impact the pressure drop across the respirator, and it can also do things like degrade the plastic so that it doesn't form fit to your face well. Only the respirator manufacturers can really reliably provide guidance on how their materials can degrade with various cleaning and disinfective methods. We know that various groups like NIOSH have looked at it, but nobody's really come out with any formal recommendation for disinfection. I should point out, though, that there are devices that are meant to be reused, like PAPRs and some of the elastomeric masks. These have cleaning instructions, and they can be reused, and you should always follow the manufacturer's instructions on cleaning these reusable devices.
Barb, if I could just jump in, I've heard that folks have used N95s. Obviously, they have to be fit tested, right? That's an important part of it. Otherwise, they don't have the efficacy they're purported to have. But I've heard that some folks have actually taken to, when they have them, putting a surgical mask over the N95 as a way of basically protecting the N95 from contamination. What do you think?
I have heard that, and that does protect the outer surface of it. I haven't seen that recommended by any group like the CDC, but I have heard that being used. Obviously, you know, one concern with the reuse is that you're going to be touching and manipulating the outside of it and contaminating your hands, and then when you're putting it back on, so by using a surgical mask, you dispose of that surgical mask and then just reuse the N95.
Barbara, we also have a provider who asks, you talked extensively about, eye shields and gowns and things like that. They don't have gowns, they don't have eye shields, and they can't find them now because of, the issues with supply. What is the recommendation? We saw some recommendations, individuals in the chat who are mentioning, people are using hockey masks and other type of sports equipment as eye shields. Are there any recommendations or guidance for providers that you can share on that subject?
So the CDC does have some recommendations online for extending use and what to do with PPE in these kinds of situations. There have been some use of things. I think the CDC mentions using bandanas or scarves to cover your mouth. That's not really considered PPE because it hasn't been studied in any formal way. I think you can try going to your county OEM for supplies if you're really in dire straits, and they may be able to have some available for you.
For our eye shield, I've heard also people using things like, snorkel masks, or swimming goggles as eye shields.
It's possible, again, that's nothing that's been formally recommended. Anything over your eyes is better than nothing over your eyes. But again, not a formal recommendation.
Yeah.
And then sort of along the same lines with supply chain issues, we got a number of questions about hand sanitizers. So where can providers procure the alcohol-based hand sanitizer since most places are out? Are there any thoughts? Is it OEM in the counties that we should be reaching out to?
For supply issues, yes, we always recommend that you reach out to your county OEM and they can try to make it available. One thing I do want to mention about hand sanitizers is that the CDC does recommend the alcohol-based products. There are products on the market that have benzalkonium chloride. Those are not recommended for COVID. Because the CDC doesn't have good data on that. So we really need to stick with the alcohol-based, at least 60% alcohol-based hand sanitizers for this particular event.
And of the alcohol, do we care if it's isopropyl or ethyl alcohol?
No, either one is fine. You just need to make sure that it's the right concentration, at least 60% alcohol product. I've also heard of people using alcohol directly out of the bottle on their hands if they can't find a hand sanitizer. We don't recommend that. That's very drying to your hands. And if you're using it very frequently, you can get degradation of your skin. And that's obviously not a good situation if you're a healthcare provider to have skin breakdown. So we don't recommend that.
We've also seen some folks in the chat sort of sharing practices and mentioning that pharmacies may be compounding, or compounding pharmacies may have product available as well. I had another question about the hand sanitizer. What are the options for individuals who have allergies to the hand sanitizers or to a certain formulation?
Probably frozen. Hello, can you hear me?
Yeah, hi.
Sorry, we got muted for a second. It depends on what the person is reacting to. If it's one of the emollients within that particular formulation, you may be not sensitive to another type of hand sanitizer. So you should check with your physician and see exactly what you're reacting to within that hand sanitizer, because you may be able to use another alcohol-based product that has a different emollient in it.
I did have a few more questions for Paul that I wanted to revisit. Paul, we had a number of practitioners on the line, providers concerned about liability. So I'm curious to know, from the consumer affairs perspective, do retired providers re-entering the workforce need to explore malpractice insurance for them, or for folks who are volunteering with regards to their liability? Can you talk a little bit about that?
So the liability question is something that I will say we're very attuned to. It's something that we're looking at and seeing. But right now, certainly, I would say that any practitioner, whether or not they're coming out of retirement, whether or not certainly with regard, I'm not sure, it doesn't sound like the question is specifically with regard to telehealth, but with regard to telehealth or in person, it should be mindful of liability, certainly. With respect to telemedicine, the liability, just like everything else, and we talked about the record keeping requirements, the standard care requirements remain the same. And so certainly to the extent that there are liability questions, again, whether or not you are practicing in person or not is not going to have an impact on whether or not you need liability insurance.
And do you have any thoughts about how sort of urgent care providers or walk-in clinics can utilize telehealth in their practices?
So, I mean, again, that's really up to them, and we are not, as while we promulgate the regulations, we are not standing in for the clinical judgment of the provider. So that really is up to the provider. Although I will say that to the extent that telehealth and telemedicine can be used in an urgent care setting as well as any other office-based setting to help screen patients, to help provide guidance to keep them either keep them from coming in the door or keep them from coming back. They're very encouraged. One of the questions that was provided earlier was about whether telehealth could be provided within a specific facility. So, for example, in an urgent care setting or even in an inpatient setting, if a doctor wants to provide the service to a patient who may be in another room or another floor, is that appropriate? And the answer is yes, it would be just as appropriate in that setting as it would be if the patient was at home. And that is something that providers have asked us, in a setting like that, for example, if you wanted to screen a patient to see whether or not it would be necessary to have an in-person interaction, they can be, a patient, to the extent that you had the facilities available, could be segregated in such a setting.
I think there are a number of challenges that we've heard from providers with regards to using telemedicine, even across generations, and older adults, and some barriers perhaps. So I think a plan would be to really explore and spend a whole session in the future related to this telehealth issue, because there are so many challenges, even with regards to reimbursement, that I think we've not even scratched the surface with today, to be honest. I wanted to get to one question. I'm not sure if this will be for Dr. Montana or Dr. McHugh, but we have had some providers ask about antibody titers. So are we doing any antibody titering at this point?
So I know that there are some antibody tests that are some IgM and IgG tests that are currently on the market, or have recently come to market, or will be recently coming to market. And it's unclear how best that those tests could be utilized in clinical settings. So I do think that we need to understand a little bit better about how antibodies are generated and how quickly they are generated before we determine their usefulness. They will probably be a little bit more useful in settings to understand individuals who may have had subclinical or asymptomatic infections. And so I'm not so sure that they're going to be as useful in the acutely symptomatic individuals.
Just one thing to add, I mean, there are studies looking at collecting those antibodies from people and then infusing them into individuals as treatment for people who are particularly impacted by COVID. And there's also a thought that perhaps those antibodies can be given to individuals as prevention for high-risk people. But again, that's, you know, down the line and still being studied.
This is Dr. Resnitz. I wonder if Paul could say something about the new policy that went out from your office on the use of hydroxychloroquine and azithromycin. I know there was some comment about that.
For sure. I mean, just as a general matter, we have put in place restrictions on both the prescribing and the dispensing of drugs that are in short supply in the state. And for that, I think the most important thing to note is that it exempts any inpatient prescribing. It exempts prescriptions that are made with regard to pre-existing conditions or prescriptions that are made in connection with any form of clinical trial. Now, outside of that setting, what is required is a note on the prescription if those prescriptions are being made with respect to COVID for the purposes of treatment of COVID-19, that a positive diagnosis be marked on the prescription itself.
Diagnosis code on the script. I think that's really important to keep in mind here. We've received a number of questions related to treatment, to maternal, child health, pediatrics. I think it's really evident that in today's session, we've just begun to scratch the surface. And certainly this is just the start of an ongoing dialogue on this critical issue. As we approach the end of today's ECHO session, we want to thank everyone for their attendance and participation. This session, again, has been recorded and may be distributed after the call. We would appreciate your feedback regarding interest in participating in subsequent sessions on this subject. So we encourage you to take a few moments as we conclude here and complete our activity survey. So again, we can gauge your interest and help plan for upcoming sessions. Dates and times for the next and upcoming COVID-19 ECHO sessions will be announced at a later time. Thank you all again for your attendance and be well.